So we are recording. This is AP for February. It's February 13th. Valentine's weekend. Happy Valentine's Day. And we got a small group, but a lot of people are taking advantage of the recording. So hopefully we act like we know what we're talking about. How's that for a plan? Does that feel like a plan? So Joanne, by the way, I did get the DVDs.
Oh. Awesome.
Yeah, I got those. You've got one though, right?
Yes.
So anyway, I have those. I got 10 of them. So I'll have them for next year if somebody wants them.
Yeah.
And then I also, I'm going to show everybody this. I also was able to, not with the clinical massage book, but with my sports massage book, I was able to move over a lot of the videos there. So I want to show everybody where those are at. So let me share the screen. And what do you guys see? Do you see the dashboard?
Yes.
Okay. There we go. Okay, there's our advanced practitioner on Canvas. All right, so when we look at this, we've got our glossary and we've got a general massage protocol here. And then this is the stuff that goes with each chapter. And the questions are right here, the tests. And we go all the way through all of this. That's why I'm scrolling through this so that it shows up on the recording. And then we get down here where it says additional content. This is where I was able to get some more stuff put in through here. So I've got a stretching protocol we'll look at real quick. This, I think, is a different video than the one we had before on a general protocol. I'll have to click this to know what it is. I've got some, I was able to move some business and professionalism skills over. So if you look at that, like, you know, who knows what you're going to end up doing, Linda, but eventually I mean, your intent has always been to be in business for yourself. So there's stuff here on every chapter where you can look it up and, you know, that when that time comes, you know, that stuff is there available for you. So
will this always be available to us?
I don't ever take you guys off of it.
Okay, that's good.
Yeah.
Because I can always go back and reference then.
So let me get back out of there. Okay. So then if we get down here, where we've got evolve resources for sport and exercise, if we hit that, and then you come on down through, and you get to review of massage methods, and you hit student resources, prepare for class and/or lab. There's your massage technique videos.
Wow, I'll try and remember all that.
All right, well, it'll be on the video. So lots of times you have to give your, you have to click here where it says videos, click here. So here on focus massage application, we've got lymphatic drain.
Good.
and we've got specific releases.
Begin the sternocleidomastoid release by identifying the muscle.
So it goes through and shows all those ones that we have learned.
The muscle is inhibited by grasping or pinching the muscle. This is pectoralis minor.
Okay.
Begin first by softening the pectoralis major muscle tissue. Pressure is applied at a 90-degree orientation.
That's your suboccipitals.
An alternative method can be a 45-degree approach with the stabilized hand while the client moves their head in a circle. Compression of the lower ribs is part of the release.
That's diaphragm.
As is extension of the lower ribs. Contact with a braced hand.
That's the
compression of the hamstrings is effectively applied by kneeling as shown.
Shows how to work the hamstrings. That's when I was
to
more
facilitate the release. Movement can be added by instructing the client to move their knee back and forth. It is used to address these muscles.
There's the metaphyllae, or it's the deep rotators.
The sartorius muscle is best addressed by applying inhibitory pressure to the muscle attachments and then having the person activate the muscle anteriorly rotated. Then the leg is positioned again in the direction of ease to further anteriorly rotate the pelvis. The leg is then moved back and forth between anterior and posterior rotation positions.
So all of those
if the pelvis is outflared, the leg is positioned to
and then this shows everything.
Lymphatic drain and other circulation enhancing methods are incorporated into the general protocol. Here I will show you the application of various lymphatic drain methods.
Here.
When beginning lymphatic drain procedures, it is important to prepare the thorax so that the drainage area
and then here's a general protocol, and it's got it by area. So let's look at the torso.
Massage of the torso begins with assessment.
And
if areas of bind or muscle tension are identified,
that was the intent of the book.
Combined loading, in this case, compression plus movement, can be.
So if I go down and look at the foot. So these are good reminders, and you might pick up an additional idea.
It is important to make sure that the range of motion of all the joints in the foot are assessed and addressed. Rhythmic compression. Mobilize all of the joints in the foot so that the dorsiflexors in the athlete often shorten. Being demonstrated is an active release technique to lengthen these structures.
Now, the ones in the clinical massage book are different. They're with different populations, but the methodology is the same. The stretching atlas is pretty cool because it's got all the muscle energy techniques with it.
Muscle energy techniques involve positioning the body. Inhibition is introduced and the quadricep-resisted joint movement is used. Forth until the result you want to achieve is reached.
And then in addition to that, the assessment in here is really good. So all of these different planes.
Multiplanar assessment or functional assessment is a method of identifying where muscular and movement imbalances may occur.
But it's hard to remember all of these. So
when performing assessment, observe for areas of asymmetry. short structures, and weak muscles. By performing this simple assessment, the massage therapist can begin
all
to
the firing patterns.
Firing patterns are muscle activation sequences. Muscles should contract in an optimal sequence to produce movement at the joints. The following firing patterns are the most commonly disrupted in the athlete. The first firing pattern is trunk flexion. Fingers are placed on the lower abdominals and the client is asked to curl. The rectus abdominis should not contract as shown in this demonstration. Instead, the client should perform the draw-in maneuver so that the lower abdominal muscles are activated, and those muscles should contract
They're
first.
pretty well explained, so if you've seen them once, which you have,
the hamstrings or the gluteus maximus can contract first, but the erector spinae on the opposite side should not be the first to activate.
And then this is the gait assessment, which people, it isn't used as often as it should, but somebody like human.
Gait assessment is a method of muscle testing for functional muscle units that work together for coordinating cross-body movement during gait. The most common problem is that muscles do not inhibit when they should, although occasionally muscles will assess weak. The assessment is performed by mimicking the cross-body gait mechanism. Begin by positioning the leg and arm as shown.
So all we're doing is mimicking gait.
Apply a resistance force against the leg and assess the arm against it. Reverse and apply a resistance force against the arm and assess the leg against it.
Often.
Both assessments should indicate a strong facilitated muscle response. When the flexors of the hip are contracted against a resistance force, the extensors of the contralateral arm should
assessment.
The following assessments can quickly help you identify the type of low back pain the client may be experiencing. With the client prone, if compression is applied bilaterally and down toward the table, and the symptoms increase, the psoas may be the cause. If the pressure is applied against the SI joint and the symptoms increase, then the SI joint is the potential problem. If pressure is applied only to one side, either prone or side lying, into the quadratus lumborum, and the symptoms increase, then the likely cause is quadratus lumborum dysfunction. When the client is lying supine, if the hand can be slipped easily under the low back, the psoas is likely short.
So some quick screening for you. So there's a lot of information here. And then let's get back out to the stretching atlas. These are more pictures, which is nice. Here's the cervical sequence. So you just hit it and it gives you a kind of an example of what to do with it. And again, it reminds you of the pattern that goes with it. So those resources are now up there and should, this is the protocol. Yeah, this is the one I showed you where it's by location. So I think that, especially with us being remote, I think that it is helpful to know that those reinforcers are up there. They don't take the place of hands-on learning, but if you've had a hands-on experience with it, then you can go back, you know, and when you were in your entry-level class, Linda, you we showed you stuff that is a small class. And so we showed you stuff probably that was over and above what we typically show in entry-level training. So,
yeah, I'm glad we made it through the hands-on part of that.
Yeah, we did. And now you combine these resources with how it's done on a different body in the DVD for the clinical massage book. I think that you'll find that you'll have some nice reinforcement there. So let's get back out to this. And so that's all the stuff for sports massage. Well, let me do this different. Nope, 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 nope. Okay, just had to click the right button. So, and then just as a reminder, right here are your questions that you need to be plugging away on. And they'll show up in the grade book. So just plug away on those. Doesn't want to preview it for me. That's what happens when I'm in instructor. Oh, there it goes. I'm in instructor mode. So Linda and everybody that's watching the video, you just want to keep plugging along. These would help if, as a review process, if anybody wanted to challenge the board certification exam. So we can talk about that later on in the year. So I just had, Joanne, do you remember Brenda? She was, yeah, she was in the year before you, Linda, and she did take the board certification exam and she did pass it. So she said it was convoluted. These exams are very convoluted, but she managed to bumble her way through it. So now today, let's get back to us today. If I look at announcements, so there's our Zoom link for today. But this is some resources that are going to show up on the PowerPoint when I get to them, but I want you to see that they're here. So this is a questionnaire that Dr. Chadow taught us to use to assess for how significant a person is experiencing breathing pattern disorder. And there's a link here to where you can download it. So these symptoms aren't always connected as that there's something going on with breathing function. So this is a nice resource to have. And once you look at these, what you're going to realize is that these are all related to sympathetic autonomic nervous system, the fight or flight activation, but we're not using the musculoskeletal system or the adaptations in the circulatory system and so forth to actually expend that energy. So we have these symptoms rolling around in us that there's really nothing wrong physically, but it feels yucky. And people have a hard time sometimes getting diagnosed with what's going on with this. So the ones that you need to make sure that you're careful about always referring to make sure that there isn't something else underlying that would be obviously chest pain, blurred vision or dizzy spells, or feeling confused. These three right here would be an indication that there's a change in mental status. these two right here could be just a positional hypotension where people stand up too fast or something, but it also could be a little bit of an indication of stroke. You know, there are many others that go in with that, but you want to be safe when you're working with people. You also have to be aware of shortness of breath and tingling in the chest, as well as some bloated feeling in the stomach. For women in particular, this may be more of an indication of a heart attack than pain down the arm, which, you know, so if you see this cluster, then you need to not, you know, you need to stop and go, you need to get checked out, kind of a thing. And then as a result of the sympathetic autonomic nervous system, your heart is beating faster because it thinks it's supposed to be pumping more blood because you're running. You're supposed to be running, but you're not, right? So you become aware of your heart beating faster. And then the other part of the fight, fear, flee, freeze mechanism really brings up your anticipation of what's going on. Because that's telling you something's wrong when those things are there. But there's nothing wrong. There's nobody breaking into your house or anything like that, but your body thinks something is going to happen that's bad, or something is happening that is bad. And so when you can't find an event, like, you know, somebody's trying to break in the house, for example, there isn't anything that makes sense or is logical, that can manifest as anxiety. So then that just, now you've got a bad circle of everything that's going on with that. Now I'm way better than I used to be on all of this. But years ago, I was diagnosed with primary anxiety and OCD. And that's another type of an anxiety disorder. Once I learned to breathe and understand this better, a series of things happened that made a difference. One, again, years ago, I finally was diagnosed with that benign proximal vertigo, which is the otolith crystals in the wrong spot in your ear. And even though I might not have the extreme vestibular imbalance where I can't stand up, I mean, that happens once in a great while, and you throw up, you know, and all of that. There was that undercurrent of not feeling right and not knowing what was going on. And even though that didn't change, understanding how that fed into the anxiety made a big difference in how I coped with it. The other thing is Dr. Chadow taught me how to breathe. He pointed out that I was an upper chest breather and all of that. And I've been really successful with reversing that, which brought down the sympathetic autonomic nervous system. And so everything that I know about this, I primarily learned from him, but I've also lived it in my own life, so I can kind of relate to what's going on with it. Now, many others, since years and years ago when he taught me all about this, they're starting to have more of an awareness on that. And we're going to look at some video clips of an individual that I think does a nice job explaining it. And the thing that did not change in all of this was the OCD, the obsessive compulsive type stuff. But that has been helped with medication. So it's been interesting for me to be my own guinea pig to experience all of that. And I still get it. right? I still have, these things are still present, but I've got control measures with them. I'll go, gosh, I'll bet you I was doing this, or yep, sure enough, you know, that was going on, or I need to move around a little bit and shift my oxygen, carbon dioxide balance or whatever. And so a lot of people, a lot of people have these ambiguous syndromes that don't have a hard diagnosis on it. And they know they don't feel right, but nobody can really find out what's wrong. And the issue with this hyperventilation issue, or this breathing pattern disorder, which is subclinical, is that there truly is nothing wrong. It's just a normal physiological process that's happening at the wrong time, like in the middle of the night. You know, that kind of thing. So we may play this little video on how to unblock your nose. We may play that one briefly so you can see how to do that. It's really interesting to watch this individual work with a child who has frequent asthma issues. And then a couple of other videos here. This is and I might have shown this to you, I don't remember. This is about an hour and a half long video. It's focused on chronic pelvic pain, but it's Dr. Chadow explaining that. And a big part of chronic pelvic pain is breathing issues. Because the diaphragm muscle itself and the pelvic floor, they operate on the transverse plane and they act like agonist antagonist to each other. So if your diaphragm isn't working right, then you're going to have dysfunction in the pelvic floor. And pelvic floor pain is way more common than people will admit. We are seeing some awareness being created, you know, with commercials for leakage, urine leakage, or other types of incontinence. They're advertising the various products. So there's beginning to be a little bit more awareness with that. So that's what this is where these resources are for you. And let's go to announcements again. When I put the Zoom links in for you, right there is your PowerPoint. It's usually down here at the very bottom. So any of the other links that I have on the PowerPoint presentation, they're there, you know, so you can open them up and find them there. And then when I'm in the process of, I agreed to do the revision work for Dr. Chadow's books on muscle energy technique, positional release, that sort of thing. And in fact, up in this other, right here, one of the videos is Dr. Chadow explaining how he does trigger point stuff, which was part of the DVD structure for the trigger point book that he and I wrote. So, so I'm in the middle of that for muscle energy technique. So when I am going through all of that and I find something, then I post it up for you. So this one says great information. Now, right now, I can't remember what it is. Oh, this is Dr. Greenman. He is so very cool. Did I show you this one last month, Linda? Do you remember?
I don't think so.
So can you see that it says College of Osteopathic Medicine?
Yeah.
All right. These are all videos of Dr.
Oh, yes, because I'm down to cervical spine watching that, because each one's about an hour or so long.
Yeah, isn't he good?
Yes.
And the thing that I have found with researching this book for Dr. Chadow, this update for muscle energy technique. These originators, these thought leaders, way back, 50 years ago, 60 years ago, how they do stuff hasn't changed. So you can watch a video of Phil Greenman or Vladimir Yanda or Carl Lewitt or John Manel, all of these people that are in a generation that have all passed now. They're all gone. Dr. Manel has passed. Phil Greenman has passed. Dr. Chadow has passed. Yanda is gone. Lewitt is gone. And so there are the next generation that came up that we learned under them. So there's a chiropractor in California named Craig Liebenson that I've actually shared football players with him over the years. Various players, either from the Lions or the Steelers or whatever, because when they would go back to California, a lot of them lived out there. He would see them, and then I would see him. It was, and so, and me, and we're trying to carry on that legacy, honor that legacy. But all of these people, if there was something that they had taught that was significantly wrong, they were all set up so that they would adapt and adjust to that. So what has changed is the theory around things. So, for example, if you look, when we were looking at the sports massage book, it talks about one of the mechanisms of actions for muscle energy technique is reciprocal inhibition. And that was correct at the time. And we still use contract, relax, antagonist, contract, that kind of thing. We're still working with that. But research has shown that the reason why it works is not due to an inhibition of the contracting muscle to the other one. That is occurring. That's part of physiology. But that's not why we can get an increase in length in it. What more current research has shown is that contract and relax is increasing the person's tolerance to that stretchy sensation. Somehow they're not as fearful as for that stretchy sensation. And they've even found if you want to lengthen the hamstring, you don't even have to contract the hamstrings and the quadriceps back and forth. You can contract the arm and it'll still feed into that increased tolerance of stretch. So that's changed. So when you're watching these originators, when you're watching their videos, occasionally you will hear them, me too, from, stuff I learned 30 years ago. I will say something that research has not necessarily supported, but it doesn't change what I was doing or what they were doing. It changes how we understand the result of it. Does that make sense?
Yep.
So that has been really brought forward to me in as I have worked to update like this book on muscle energy technique. And even something that seems new, like hypermobility syndrome, generalized hypermobility and underlying hypermobility and all of that. They were talking about that back in the 50s as being an underlying cause of actually stiffness, especially as a person gets older. And then that's why if you loosen them up too much, their symptoms actually increase. But when people are younger, they're more prone to injury and they got a lot of chronic pain related to the muscles having to provide the joint stability. So anyway, I'm glad, Linda. I'm really glad that you're working your way through these, because a good part of that information is within our scope of practice. And that you're savvy enough, anybody that goes through health enrichment centers should be able to truly discern when something is out of their scope of practice. And then that would be an indication of a referral. So, so good for you, good for you. And so, and down through that, if you go through the rest of these, if you go down through the rest of these announcements and through here, you will find, so this one here is excellent assessment videos, because I teach you about the same soft tissue assessment that an osteopath, I mean, there's only soft tissue. It doesn't, you know, if I'm assessing for something that is short or long or whatever, as a massage therapist, I'm going to be assessing it the very same way that an osteopath assesses it. Where my limit and scope of practice would be is if it's really what they call osseous, so it's specific to a joint, especially if there is a joint or an osseous / bone impingement on a nerve. Not soft tissue, but bony impingement, like if the spine, if there's stenosis in the spine, which means the little holes that the nerves come out have gotten little spurs and stuff, or the little hole is collapsed. Those are referrals. But that doesn't mean there isn't stuff we can do, but we need to be aware of referral. And then we also have to go, how fragile is this person? And how complicated is it? So the more fragile and or more complicated and or / more acute somebody is, the more likely we would want to consider referral to a physician, a general practitioner, or an osteopath, or chiropractic, depending on what seems most appropriate there. And we can now direct refer to physical therapists. Each of those professions should be able to screen for stuff that could be really serious, that would require a surgical intervention, or it might be an underlying cancer or something like that. But once we send them on, then it's those other professionals that are responsible for finding it.
Okay, if we can defer to physical therapists now, don't we have to write a script or something for that?
They can take direct now, but they had to move their entry level degree to a PhD to do that. So we have a physical therapist in Lapeer, Brian, that at the spa we regularly refer over there. And they're more versed in rehabilitative exercise than we are. And they can also bill insurance. You know, there's some insurance reimbursement that, depending on a person's insurance, that they can get from that. So while we do the same assessments and many of the same methods, we do have some hard stops on when the scope of practice for massage ends, like we don't adjust joints. Now, I do teach you an indirect method for joint play, I do, but there's little chance for injury in an indirect method. There's much more chance of injury in a direct method. And what the difference is that in an indirect method, you're moving away from the restriction. You're not pushing the tissue towards the restriction, which is where the injury can occur. You're moving it the way it wants to go. And then the person then provides the force, like they move the thing in a circle or something. They provide the force to see if they can move the structure. Whereas a high velocity thrust or some other mechanisms that an osteopath or a chiropractor might do would push that structure back where it belongs. And there is more potential for injury when that occurs. So, and then again, that idea of are they really, really acute? Are they in really acute pain? Is there an underlying injury that needs to be diagnosed, like a sprain or a strain or a stress fracture? Or I've had cases where there's been a bone cancer in the area that was just starting, and they had pain in the area, and it just didn't respond to anything I did. And so they went to their physician, who didn't catch it right away either. Then they had an x-ray and they saw the change in the bone, and then it went on and was diagnosed. But they caught it early, and that's the point. The person was able to be treated pretty successfully. Whereas if it had progressed and progressed and progressed and progressed, then it would have maybe been too late. So, but we don't have to go, I think you've got bone cancer. We say, there's something here that I don't understand, and the methods that should make a difference if it was primarily a musculoskeletal issue are not making a difference. So there must be something else going on. And I don't have the diagnostic technology nor the expertise to look for that. So you need to go see somebody who does. You know? So if they go to a chiropractor, the chiropractor should be able, with their diagnostics, this person that I know didn't go to the chiropractic first, but if they did, they should have been able to find that suspicion that there was some bone cancer or something, some changes with the bone. And then it would have been their responsibility to refer to the next level. So we've got a little bit of a safety net. We get into trouble when we don't refer. You know, and so if I refer and then a person comes back and they say, like with this breathing stuff we're going to talk about, that they didn't find a heart problem, they didn't find a mitral valve prolapse, they didn't find an inner ear issue. These are all things that can mimic that. They didn't find anything. They have cleared it for some sort of anxiety or something. Now I feel confident that nothing's hiding, and that, you know, we can work with the breathing pattern stuff. So anyhow, when I'm finding stuff related to this work that I'm doing, I'm stashing it here for you. All right. Any questions on any of that stuff, Linda, or even Joanne? Joanne knows as much about this as I do.
No.
No questions. I do like Dr. Greenman. His book I have is excellent.
Yeah, yeah. I met him briefly one time when Dr. Chadow was here. And but they were colleagues. You know, they went back that whole generation. I was so fortunate to have been able to have that generation, primarily through Dr. Chadow, but to have access to that generation while they were still alive. I remember I had John Manel was in Canada, I think. And he's the one that does all the joint play, the indirect joint play that I teach you guys. And I had scheduled a class to go see him. And he passed away before I got to go to the class. And I always remember that, in the sense of, if you have an opportunity to learn from one of the real masters, the ones that have been out there forever, that have learned in the trenches, that have had exposure, you know, they've been in their own little network, like Dr. Chadow was with that whole group, Travell and Lewitt, and, you know, all of those in there. And, you know, you have an opportunity to just be in their presence and watch them. They may not even have any new quote information, but just to watch, you know, how they puzzle their way through something. You know, it's kind of interesting. Now, Stuart McGill, he's still working. He's up in Canada, and he was just kind of like, quote, a baby when these people were coming in. He's a physical therapist, I think. I don't remember, but he's kind of the one that is left. And then there's Craig Liebenson, who's a chiropractor. And to a much lesser degree, I fall into that category a little bit. But because of my long-term relationship with Dr. Chadow. So, okay, let's go back to the share screen and look at our little PowerPointy thing here. So where we're concentrating is Unit 3 in the clinical massage book. So I wanted to show you this before I screwed up here. I wanted to show you this before I left here. So if I go down to the ebook, Vital Source here, you're able to get into this now, Linda, right? I mean, I know you found the paper book, but so
yes.
Here's the clinical massage book. And it's Unit 3 that we're really concentrating on. And you know, if you start to go through these, this is where most of the AP people are at. They get how to do the stuff. Like they know how to do muscle energy technique, or they know how to do subscapularis release or whatever, but they don't know when to do it. Hello, Kiki.
Yeah.
So if we look briefly at these chapters, and just kind of scan through them just to lay a framework here. This is the content here in chapter 3 is gonna lay the foundation for when a person is starting to show pathology versus normal adaptive capacity. And then our ongoing discussion here between hurt versus harm. And this is the pain dilemma, the chronic pain dilemma that we've talked about before. Acute pain signals harm, which means something is being cut or eaten away or burned or overstretched and torn or something like that. And that is going to hurt there's going to be a pain sensation there because it's trying to tell us don't do that or stop that or something bad is happening. Actual cancer pain falls into the harm area because you're getting ongoing cellular trauma. The cells are being destroyed in where the cancer is invading. But so many people are living beyond a cancer diagnosis, and they're experiencing chronic pain type sensations that were more related to the treatments. So more related to the surgeries or to the chemotherapy or the radiation. But because they had this experience of the acute type pain that's directly related to cancer cell invasion, it can get a vicious cycle on what's going on with that. And chemotherapy can cause a real, it can disturb the nerves. So does radiation. Radiation is a burn. So people who, like say, more and more and more are living, we find that we're in a situation where we're dealing with not the cancer, but the results of the treatment in long-term, remission or whatever. And some of this is really hard to navigate, especially the neuralgia, the nerve pain is really rough. And then another thing to understand is cause versus symptom. So one of my current students, she's a dance teacher, and somehow or another she stepped funny, and she tore something in her calf. And now I think it's one thing, but the MRI and the expert, the physician, are calling it something else. But the treatment is the same regardless of what it is. But she's got severe pain in her calf, and she's got a lack of stability in her ankle and her knee. And I think she damaged a little muscle back in there called plantaris. They're calling it a calf tear down closer, or the gastroc tear down closer to the Achilles. Regardless, it's the same area, and it doesn't matter. There's no sense cutting hairs on something like that. The treatment and the healing progress and all that is the same. But she's got, especially in her mid calf, she's got a deep, a real deep knotty pain. Now, to me, that's an acute injury. There's a cause for it. It doesn't really matter exactly what tissues were torn. But the whole calf is trying to bring the ends of that torn tissue together so that they can heal, just like if something was sutured. And that's where you're starting to get that deep knotty pain. It's that guarding, that sort of thing. So the guarding is the symptom. So the cause is the tear. But what's bothering her is how the body is trying to heal the tear. And so, we talked about it and used it as an example in class. And, she's a dance teacher. She's a dancer. She's entering into a massage career, not being able to stand on your leg, that's got to be really scary, right? And so, you start to have, start to, anybody would go, what if I can't? What if I can't? What if I can't? But if you can help them understand the difference between the cause and the symptom, sometimes that alleviates some of that anxiety around through there. And then, of course, we have prevention methods that we want to talk about. So there are things that make us susceptible. When we're tired, we're not as careful about how we move. If we're doing something wrong, or we have repetitive motion activities, the stuff we were talking about earlier, Linda. As we age, it changes our adaptive capacity. Now, more and more research says that symmetry and posture and an upright posture is not as important as they thought in terms of how people function and their symptoms. But it makes logical sense. There's some biological plausibility there that the more deviation off of a norm, the more energy it's going to take to function. And then you get up into these other areas of maybe there's some fatigue or something like that that goes with it. And then the more you deviate off of a normal posture, the more you're going to have areas that are more short and others that are more long. That's that whole cave hill situation. So here is some common postural imbalances that you would find. And I wouldn't say, oh, this is why you have pain down your leg or whatever. But it would play into the decisions that I would make on how I would address the body, which first I would want to identify the deviations, the caves and the hills, the shorts and the longs. I would then want to determine, is this more of a soft tissue issue or more of a joint issue? And then I would want to check to see what their adaptive capacity is, and is this resourceful compensation? And then I would look to seeing if there can be a little bit more length that feels appropriate, a little bit more length into those short areas, and possibly some therapeutic exercise to bring back a little bit better tone in those long, weak areas. That's how I would approach something like that. Muscle weakness can come from a lot of things. Deconditioning, it can be a neurological issue. It can be an inflammatory issue. It really is something that needs to be sorted out on why it's there. Also our lifestyle. We were just talking before the recording went on about how our exercises, you know, to keep ourselves healthy. Joanne's out and about shoveling snow and all of that. Our sleep cycle, all of those kinds of things can also make us more prone to injury and illness. And then we also have all of our psychological stuff that goes with it. So those are the things that are identified in this chapter. Even though this book was written in 2007, as I reviewed this, the information remains consistent. There hasn't been any real changes in it. The only thing that has really shifted in this is more and more understanding of the endogenous inside us cannabinoid system and how soft tissue work is upregulating our own internal cannabis, endocannabinoids. And when this was written, there was just a suggestion of that. And now there's quite good research on the importance of our own internal cannabinoid system and how pervasive that is. And massage and exercise up soft tissue work and exercise upregulate our own functional marijuana, our own internal system. So, and then it talks about in this chapter, direct trauma, indirect trauma, chronic use trauma. So your wrist, Linda, you've got direct trauma from hitting.
Yes.
You've got indirect trauma from how you use your hand at work. You've got chronic and overuse trauma because you've been doing this for a while. And I wouldn't be surprised that if we were to explore back, this has been bothering you more and more and more. I wouldn't be surprised if
it started 2 years ago.
Right. And then it's ebb and flow. It's always been there, but it's been better and worse and better.
Yes.
Okay, so in the last month, it's gotten worse.
Yes.
I wouldn't be surprised if we explored about 2 weeks or 10 days or even 3 days prior to you get where it really kind of kicked back up and bothered you again, if you hadn't done something.
I went back to work.
Well done. Yeah. You know, and so that's that re-injury situation. And so you have all of these.
Yes.
In relationship to that particular situation. And it appears to be, at least in part, an osseous injury. There's been a displacement of a bone.
Yes.
All right. So that doesn't mean there isn't soft tissue that goes with it, whether it's protective or guarding or because the bone is out of its normal position, that stuff stuff is being either squinched or stretched, because it's not in its normal spot. All of these things are going on. And so the treatment that you described to me is that they're hoping that if they can get the inflammation down, that there'll be just a little bit more space in there, and that bone that's been displaced a little bit will go back where it should be.
I think that's what they're hoping for, because he came right out and told me he didn't recommend surgery for this.
So, okay, so I get it. So that little thing is pretty complicated. If you were to see a massage therapist on that, if we didn't understand that there was a bone that was translated out of place just a little bit, right where that's at, that's going to be sore. It's going to act like a trigger point kind of thing if you push right on it. Well, if I push on that enough, that's just continuing to translate that bone the way it shouldn't be going.
Right.
So, the focus of this course that we're in is to help you make better decisions about all of that. And then I mentioned to you that you might want to ice. Now, the ice will do two things. It will interfere. It will address that inflammatory response because it potentially can penetrate deep enough. Show me on your hand where this thing is.
It's this carpal here, the lunate bone,
Yeah.
But it affects back here.
Yes.
And it goes into these fingers.
Yeah.
Well, now it started also going on this side. When I grip anything heavy, especially, I cannot hold on to it. I've started using my left hand for everything. So this has a chance to start healing, I'm hoping.
Now you've got overuse in the other hand.
Yes.
Not as good mechanics because you're reaching across or something.
Exactly. And I've even tried, because I've always had trouble writing.
Yes.
Using this hand to even write with because of this, before we even knew what was going on with it.
Right.
So now I'm starting to write with my left hand, which is sloppy, but this is sloppy too because I don't have control over it.
Yes. Yes. So, you know, if you were my client, I would look at you and go, well, this is funky.
Okay.
You know?
Okay, it's like life history story right there. So
my approach would be, well, let's sort everything out. Let's deal with the whole rest of your body that's compensating somehow. Let's clean up what mess we can due to compensation. Then let's see if the inflammation can come down. And then, let's maybe we can fuss with the try to find that balance between tissues that have shortened and tissues that are long because of that translation of that little bone in there. Maybe we can loosen that up just enough so that when you move, it's not dislocated, it's just
shifted.
I
have an x-ray of it. I have one of each hand.
Yep.
Because they did a comparison, which I'm glad they did, because that gave me both hands to look at to see the difference.
And that helps. Remember when we went back to cause and symptom and all of that kind of stuff? Good for the doctor, so that you could see all that, so that you could visualize it. And the other thing I would compliment the physician on is that they just didn't automatically call it carpal tunnel.
Yeah, that's what everybody at work kept saying it was. And I says, I really don't think it is. I'm not getting all the rest of the symptoms.
Right. Now, because that I think is overdiagnosed. And a lot of that's coming from the neck too.
And you also know on this side is also where I've always had that pinched nerve problem. It's always this side.
Yep. So then you've got two things going on that could cause the same symptoms.
Yes.
And then, this is another thing for referral kind of a thing, is this is a totally different situation, even though it sort of kind of feels sort of kind of the same. Then clients would say, well, how long is this going to take? A while.
Yes.
3 to 6 months, probably. So there you go. So, okay. So this whole chapter, the rest of it is going to go along and kind of talk about that. And then I want to take just a minute on illness here. Actually, before I do that, this is maybe one of the most important parts of this discussion here. This is during the phases of healing, and it also has to do with the inflammatory response, because that's what healing is the inflammatory response, if it's productive. So in the acute pain situation, that would be for massage, that would be a generalized support overall to help you cope, and not much on the spot. Does that make sense? If I were going to do anything on the spot.
Are you still referring to mine?
Any spot.
Okay.
If I were going to do anything on the spot. Now, here's how, and you can do this to yourself, Linda, because you can touch it. Here's how I can tell if it's ready to be worked on or not. So can you find the most painful spot on your hand that when you press on it, it reproduces the symptoms?
Not pressing on it. It would be gripping something tight.
Okay, grip something. Grip, make a fist.
Yep, right there.
And then can you press on it? Can you press on it? Can you find a spot once you have it? Okay. Now just let go of the grip, but keep your finger on the spot. Is it still tender in there?
No, it's only when I apply pressure and it tightens all of that up in there.
Okay. So make the grip, find the spot, and then where your finger is at with the spot.
Yes.
All right. We'll give it about 10 seconds. Does it change at all or does it stay the same? Does it get less or more?
It's finally getting less. At first, I couldn't even continue pushing on it, but now I can.
Okay, so it is getting a little less.
Yes.
All right, so continue to do that then. And now see if you can grip better.
It still puts pain up through there. I've been doing also the acupressure.
Right.
For the carpals, and that has been helping.
Okay.
Doing the 3 fingers down and then holding that for maybe 20 seconds. And plus I've been working
up there. So the assessment was an acute assessment. And you were right on the edge of whether I would work with it or not. Because it did change a little bit after 15 seconds.
It still wants right there.
Yeah.
Right there when I push on that spot.
All right, so let's try it again. Push on that spot, recreate your symptom.
Oh, I am.
All right, now tell me what happens if it starts to diminish or stays the same or gets worse.
It feels like my whole hand is getting weak.
Okay. Okay, it's getting worse.
Okay, it's getting,
that tells me it's not ready to be worked on.
Okay.
That's how I would determine.
All right.
Once I knew there wasn't anything really bad going on with it. So like the calf I explained, if I were, it's been like 3 weeks now for that individual. I would go do the same thing. I would say, find the spot for me. I would have the person find it. And then let's press on it and see if it changes. If it gets better, then I might try some intervention. If it stays the same or gets worse, it's just not ready. So that's how you can tell where you're a little bit if you're in the acute phase or not.
Okay.
Also, that is going to show if it's a nerve, because a nerve is not going to necessarily get better. It's not the sensation is not going to diminish while you're pressing on it. Does that make sense? And I'm going to work with a nerve differently than I'm going to work with soft tissue. You have a confused look on your face.
I'll figure it out. I've been doing a lot more research on this since I found out what it is. And like I said, I don't know if I am having energy healing done on it also, and that seems to be helping.
So I would do, okay, what I would do on something that says it's not ready for any kind of muscle energy technique or inhibitory pressure or any of that kind of stuff. What I would do on top of that area is something that would look like lymph drain, which you're saying that you're getting some real light touch or energy type work done on it.
Yes.
So so let's say that it's here. What I would do is just lightly touch, and I would move that tissue just very, I'd find the edges of how it wants to move, and I would just move it in there like that. Now, there's stuff that's happening with that type of a gentle hold. It's comforting. It is reassuring. You're touching a spot that's a little scary, but it's not hurting it. there's a teeny little bit of heat coming in from the touch.
Yes.
There is some sensory stimulation from a static touch, but if you bring that little bit of movement into it, where you're just slipping the skin,
yep.
superficial fascia back and forth, not slipping on it, but moving that back and forth, which is
I'm just moving the skin right now.
Yeah, and it's the same kind of intervention we're going to learn with lymphatic drain.
Okay.
There's a whole bunch of sensory receptors in the skin that are being stimulated. So that's sending information up towards the central nervous system. Now, what the central nervous system does with it, who knows? But for a little while, it could be counter irritation, another sensation on top of a sensation. It could be that it's that more generalized comforting idea that goes with it. But when somebody has an acute injury and there's not a breach in the skin, I wouldn't do this if somebody had a cut or a scrape or a surgical thing. I'd do it around it. And, I'm careful about infection. I'd be more concerned about infection at that point. But that's what I do on an acute injury is that. And, I don't know what form of energy healing your person is doing, but if they're touching that, if it's Reiki or something, if they're touching that area, or if they're generally calming you down, that's even though the energy work doesn't necessarily have a lot of research evidence on it, there is evidence on this tactile stimulation that is probably a piece of what's going on. I'm not saying it's the whole thing, but I think it is a piece of what might be going on with that. So there is something you can do in these areas where you're just moving the skin back and forth, and you're not pressing down or anything like that, and it's just very gentle. But that little bit of drag seems to stimulate the receptors a little bit more than just the hold.
Yeah.
Or if the person does just a little bit of pain-free movement, that's just another way to get the tissue to move. So when we get into the subacute phase, then my approach, whether it's an injury or an illness, is again, pain management, sleep support. That's the general full body massage. And I might be more specific with the lymphatic drain type work, like I just demonstrated. And I might be more intervention focused on the compensation. Like you said, you're working on your elbow up here.
Yes.
All right. I might be more focused with that, and maybe do some more intervention related to inhibitory pressure plus movement or muscle energy technique, or
yes,
some stretching or strengthening or something like that. I might stay away from the actual injury area, but I might be more aggressive on the compensation. And then, as we go down through this, now this is the same things. This is acute inflammation, subacute inflammation, inflammation that is starting to resolve. And so we got the same things, and you don't get rid of anything, you just add pain management, sleep support, management of edema, management of compensation. Now, support for rehab activity. So if they say to you, okay, we want you to go to physical therapy for 6 weeks, there might be some delayed onset muscle soreness or something that comes from that activity or whatever. I'd look at that, try to do something with that. If there was scar tissue, like there was an actual muscle strain, sprain, a scar, an incision, I would start to work more directly with scar tissue mobilization on stuff, which starts as this thing I just showed you. And then it gets more aggressive as time goes on. And then when we get down to the remodeling, and this is about 3 months, depending on how bad it is. This can be as early as we can look at this. This might be 2 days. And then this might be another 2 days. And this might be another 2 days. Well, now we're at a week. Okay. But it also could be, this is 2 weeks. This is 2 months. It can be that too. Right. All right. So when somebody is ill, like we're experiencing with the COVID infection, and we were talking earlier about symptoms related to the vaccine, because Joanne and I are getting ready to do our second shots. That's an inflammatory response. You treat that like if you're working with somebody, you would treat that like they had the flu. And most likely you wouldn't do anything. If somebody said to me, oh, I'm so achy, I hurt so much. I think a massage would really help. And they're 2-3 days into whatever this is, I would rather say to them, why don't you take a hot bath?
Okay.
Now, why don't you do some gentle stretching? Why don't you alternate some hot and cold on it? Because massage isn't going to help anyway, because this is a normal inflammatory response. And all massage is a demand to adapt. Now, if a person was anxious, we're taking into account here that we are protecting ourselves, that we're following sanitation and all that kind of stuff. That's when maybe some hand massage, some foot massage, maybe something, head, neck, and face, something like that. But it's truly comfort care. So, all right. So that takes us through this, it gives you more information on that. And you're good at doing your homework, Linda. So you can go ahead and finish reading through this whole thing as I scan down through it. When we get to the next chapter, this is where we are. This would be chapter hurt versus harm. What chapter are we in here? It's chapter 13. So we're now in chapter 14 here. This is our breathing pattern. This is where I wanted to get to. And so when somebody is not up to par, regardless, they're sick, they've been injured, it's acute, it's chronic, they're stressed, they're whatever, and they're coming to us for massage, then we have to stop and go, what can we do? What thought process can we have that has a likelihood of helping and making a difference and not causing any harm? And because I know, and you know, that breathing can be controlled, you can control it yourself, but so it's part of the somatic autonomic function, or we have somatic control over it. We can stop breathing, we can change how we breathe, we can do that, but it also is a way into the autonomic nervous system. So it's a way that there's potential to modulate the sympathetic, parasympathetic, and then even secondarily the enteric, that gut part of all of this. So if I think breathing is a point of intervention, I'm probably gonna have some success with somebody. That's why I can't, it's not because it's magic or anything. It's because with soft tissue work, body work like we do on a very mechanistic level, just by you know, loosening up breathing muscles, getting the ribs to be able to move freely, general dampening of the fight or flight response that happens with massage. Generally, people are going to feel better. And then they're going to sleep better. And they're going to be a little less anxious. And if they feel better, then they're in a situation where they might do some of the other things that would help. Like they might do their exercises or something. So I go back to this because it's a reliable way to intervene using all the methods we've taught you that has much more benefit, much more tendency for benefit and not a lot for harm, especially if you use those releases very carefully. Because pretty much all the releases we taught you will have an impact on the breathing. So I want you to know that this is in the chat. This is in the chapter, and I'm going to veer off of this right now and get back into some, because I know this is already here. All the assessment, what the strategies are, how you would work. You can see here's all these scaling: sternocleidomastoid, serratus anterior, serratus posterior, superior and inferior, levator, all the way down. These are all of those muscle that we try to use primarily inhibitory pressure or inhibitory pressure plus movement. That's what the releases are. Okay, does that make sense?
Yes.
Okay. So I like to bring in other people's perspectives. Now, I particularly like it when they agree with me. But, you know, that's cherry picking. You know, you have to also look at, you want to bring multiple perspectives into this. And so there has not been a lot of additional research on this, unfortunately, except with a little bit of overlap into the hypermobility syndrome, which they are spending more time researching, and the connective tissue disorders. So anyway, here's all of this in the textbook, and then it goes in and does more on pain, which we've already talked about a lot, but the two go together. And so I want to concentrate less on the pain part of this and more on the breathing part of that. Does it make sense?
Yes.
All right. So I'm going to move away from the textbook. Hi. You good? Do you need a little break? Do you need to get up, move around? Or are you good?
I'm good, but that's fine.
All right. So let's share the screen and get to our PowerPoint here. So we've looked at Unit 3 in the textbook, and I showed you the new additions to Canvas. So we've done that. You know, all those demonstration videos and all that kind of stuff. So I found a couple of YouTube videos, and I really like this Patrick McCowan. He's Irish, and a lot of what he talks about is very, very, very similar to what I had learned years ago from Dr. Chadow. But he's functioning from a newer information structure a little bit. So I really think it's about a 30-minute video, and I think we'll watch that together. But what I want to do first is show you a little bit of an assessment here. So let's see if I click on that, if it takes us to the, I guess I gotta click. Come on. Control. There it goes. Let's hopefully it takes us. All right. Can you see the?
I used to think gift giving was stressful, and then I discovered Harry and David.
See it?
No, we just hear it.
All right. So we got to do it. This is what I fall into, is I got to do it different. I got to get to it different here. So it's got to show up on my desktop. Here we are. Let me get out of the share, stop share. And then I have to go to my PowerPoint and I have to pull it up. All right. Share screen. Now you should be able to see it. Breathing pattern assessment?
Yes.
All right. There's got to be a better way to do that. I just don't know what it is. Okay. This is out of physical therapy, actually. And I'm going to increase the screen here. And let's go ahead and play this and watch it.
In this video, I'm going to show you how to perform a simple breathing assessment on yourself or for your patient. There are three main parts of breathing that you need to be aware of. Let's do a simple breathing assessment from a relaxed seated position. Firstly, with relaxed breathing, it should be quiet and occur through the nose and not through the mouth, because the nose is an important humidifier for the air before it enters the lungs. Nasal restriction may be aided by a suitable nasal spray, so encourage any patients with poor nasal breathing to visit their GP or their pharmacist. The second part of the assessment.
So, when we look at somebody and they're primarily a mouth breather, there are assumptions that you can make. The first assumption I make is everybody's got screwed up breathing. And it's not going to hurt the massage for me to include it as part of the general protocol. I may not do a quadratus thing, or I may not do a psoas thing, but reinforcing thorax mobility is not going to hurt anybody, and it's going to help. So assumption one, breathing is always a target that we can take a look at. Two, I can tell just by looking at them if they're a mouth breather, because their mouth's going to hang open, right? And we primarily should be breathing in and out through our nose. Now, the next video we're going to look at really talks about this, but his suggestion is that you might need a nasal spray. And a saline nasal spray, maybe. Potentially the regular use of a neti pot.
Yep.
So that, because, you know, we live in Michigan, you know, so we can have allergens and pollens, and we can have just kind of a irritation in the nose that's causing it to swell up in there, and eliminate that. But you can get addicted, you can get dependent. Dependent's a better word, on some of the other nasal sprays. So you don't want that. But a saline spray can help. And sometimes the saline spray is a little safer for a lot of people than the neti pot, because they don't keep the neti pot clean. You know, so that as they are swishing water through that whole nasal cavity, they might, it's not so much a bacteria, they introduce a fungus. So a lot of the chronic congestion in there is not bacteria, it's fungal. You know, fungus.
So washing the neti pot before and after each use?
Yeah. Either with a little bit of bleach or at the very least some vinegar, but you do have to watch that you're not.
Okay, I haven't used bleach or vinegar, but I wash it before and after each use.
That's probably enough, but a lot of people don't. They think, oh, that's just salt water going through there.
No, there's back flush and.
Yeah, okay, all right.
Is to check that you are breathing effectively using your diaphragm and you're not engaging in too much upper chest expansion. Simply place one hand on your sternum and one hand on your upper abdomen and lower ribs. As you breathe in, your abdomen should expand as your diaphragm flattens and expands forward, laterally and posteriorly. You can also feel this expansion from the sides below the ribs as shown here. Using your neck and shoulder muscles to expand your chest for inhalation is a poor breathing pattern, and it uses the accessory muscles. This uses a lot more energy, but it is natural for these muscles to work during considerable exertion, but not at rest and not during a relaxed breathing pattern. The third part of the assessment is to record the breathing rate per minute. In and out counts as one breathing cycle, and during the course of 1 minute, the breathing rate should be somewhere between the region of 10 to 14 breathing cycles per minute. So to summarize, a good breathing pattern should be quiet through the nose, diaphragmatic, shown by the abdomen rising and falling, and not the chest. And the breathing rate should be between 10 and 14 breaths per minute. Check.
So, we can do and these are in the textbook, we can do these assessments specifically, but it's been my experience that if you bring somebody's attention to their breathing, then they breathe funky. All right. So I've learned to be a little bit more sneaky about this. So when I'm just chatting with somebody, or even when they're laying on the table, because it does make a difference being in gravity and out of gravity, you know, I will pay attention when I've got my hand on their chest, or just lay my hand when I'm talking to them, put my hand on their shoulder. If I feel their shoulders moving or their upper chest moving, that's just a confirmation of what's going on with this. And then I might sneakily do I notice if they're breathing through their nose or if they're breathing through their mouth. I notice the movement in through here. I notice if they're doing a lot of yawning or sighing, which are big inhalations through the mouth. And then I can sneakily count that respiratory rate, especially when they're on the table. I can, I can count, and if they're going faster than 10 to 15 cycles in a minute, when I'm massaging their back, I can feel if that's going up and down. I can get a good rate on that. Now, if I'm getting lots of positives on this stuff, then I might bring it to the person's attention, because then they're, especially if they're symptomatic, because then, we can talk about some self-help sort of things. But often I won't bring it to their attention at all. And especially if I when I compare that to the rest of the history. And if they're coming in for massage frequently, I have found that the regular massage can kind of normalize this over a series of sessions. And then just some simple explanations about a little bit of like relaxation-based breathing or something is enough, because that's one of the things. if you start to bring this to the attention, especially if somebody's really symptomatic, they actually just become hyper-focused on it, and then it's worse. So does that make sense?
Yes.
Yeah, okay. So let's see if he's got anything else profound.
Check out the other breathing related videos showing on the screen here. Thank you for watching, and please like if you found this video helpful.
All right. And this one. Now the other one's a tad longer. So let me go get this one up. I really like this guy that you're gonna see here. And now I gotta go find you guys again. And then I have to share my screen. Okay.
Since we've had to start wearing these masks all day at work, I find myself even holding my breath sometimes.
Yes. And now he's got a lot of other videos. This one I'm going to show you right now. And he's got one specific to breathing in a mask.
Okay.
And once we look at this, you're going to.
I've got this cough now that it just feels like I can't bring anything up, but it just feels like I need to.
Yeah.
So I think it's causing, I don't know.
Were you breathing more through your mouth? That's drying everything out.
I think so too. When I have to wear the mask for over 12 hours a day.
Right. All right. So you still doing okay? Okay. We'll give this a watch. All right.
Yes.
Relationship between breathing pattern disorders, exhaustion, anxiety, and panic attacks. The autonomic nervous system of the body is there for maintaining homeostasis, and in doing so it regulates and coordinates many body activities including digestion, body temperature, blood pressure, and it's also associated with aspects of emotional behavior. There are two branches to the autonomic nervous system. The parasympathetic branch is taught to foster calm, physiological states to promote growth, restoration, and repair. The sympathetic nervous system activity is associated with fight or flight or mobilization behaviors and is typically activated during periods of stress or challenge. Where controlled and slow breathing comes in is that it activates the parasympathetic response, promotes homeostasis, and assists recovery and restoration of function in body systems disturbed by stress. Slow respiration in combination with prolonged exhalation may be particularly effective for reducing arousal. This maneuver for reducing arousal, for reducing stress, has been suggested by many yogi masters. In this paper, they look at 3 groups of people who practiced different breathing patterns. The first group, they inhaled quickly and they exhaled slowly. The second group, they inhaled slowly and exhaled quickly. And the third group, they had equal times in inhalation and exhalation. The researchers found that inhaling quickly and exhaling slowly was consistently effective for reducing physiological and psychological stress during confrontation periods. During rest, the ratio of the breath in to the breath out should be 1 to 1.5. The active part of the breath is the breath in, and the passive part of the breath is the breath out.
Okay. Now that's one of the things that's different than the way I learned. The way I learned it was 1 to 4. But Dr. Chadow taught me that very few people could do that. So an inhale to exhale ratio of 1 to 4 would be, if I inhale to 1, it's about a second. Then I exhale, it would be to that a count of 4. Now that should be through the nose, but he also taught a pursed lip breathing, like you're breathing through a straw, or like you were trying to flicker a candle. Just flicker it, not blow it out, just flicker it.
At arm's length.
Yes.
You hold the candle at arm's length and blow so you flicker the candle.
Now, it's better if the inhale, exhale happens through the nose. But that's hard, you know, it's hard to demonstrate. But
I'd like to see you flicker a candle through your nose.
Yeah. I could probably put it out with some
breathing through your nose to flicker the candle. Sorry.
Well, I've got that. So see, I got that persistent drainage in my nose from taking those glaucoma drops. You know, so here we're back to cause and symptom idea. I had glaucoma drops in my eyes for years and years and years and years and years and years. And so that just, I thought once I stopped taking the drops, that nose dripping would change, and it hasn't. I think it's a little better, but you know, there's that too, you know, you're constantly trying to make sure that you don't have snot dripping out of it. It's not really snot, you know, it's just a drip. And anything like that is going to interfere with a normal regulation of this breathing function. So, okay.
Okay, can I touch on something? In my energy healing class, if you were overstressed, over upset, or over whatever, they said to take a breath in through your nose and hold it for 3 to 4 seconds, then release through your mouth, and do this 3 or 4 times in a row. And it actually helped calm me down faster than anything else that I've ever tried.
Yes. And this is what he's based on. You're going to see that breathing pattern is going to be reinforced with some of the other stuff that you have learned from other disciplines.
Okay.
All right.
Out. But it's when your CP, when the control pause is high, above 25 seconds and ranging on 40, that breathing becomes light. And with light breathing, you've got a light, gentle, slow breath in, and you've got a relaxed, gentle, slow breath out. Individuals with a higher CP have a slow breath and they have a prolonged expiration. Conversely, individuals with a low control pause, low breath hold time, they exhibit faster breathing. Faster breathing is agitation of the mind and less likely to be calm. Very interesting study published by Stanford in March of 2017. Scientists in Stanford Medical School, they identified a small group of neurons that communicates the goings-on in the brain's respiratory control center to the structure responsible for generating arousal throughout the brain. So this new structure in the brain which they identified, it's spying on your breathing and relaying those findings to the rest of the brain. The structure, the locus coeruleus, it sends projections to practice.
So this is new research, okay?
Slow breath out. Individuals with a higher CP have a slow breath and they have a prolonged expiration. Conversely, individuals with a low control pause, low breath hold time, they exhibit faster breathing. Faster breathing is agitation of the mind and less likely to be calm. Very interesting study published by Stanford in March of 2017. Scientists in Stanford Medical School, they identified a small group of neurons that communicates the goings-on in the brain's respiratory control center to the structure responsible for generating arousal throughout the brain. So this new structure in the brain which they identified, it's spying on your breathing and relaying those findings to the rest of the brain. The structure, the locus coeruleus, it sends projections to practically every part of the brain, drives arousal, waking us from sleep, maintaining our alertness, and if excessive, triggering anxiety and distress. Now, this is very interesting, not just in terms of anxiety, but also in terms of sleep. One of the phenotypes of obstructive sleep apnea is low arousal threshold. A low arousal threshold means that the individual, that it's very easy for them to wake up out of lighter sleep, that they have sleep fragmentation. So what this is saying is that the newly identified structure, by spying on your breathing, that if you're breathing fast, you're more likely to be driving arousal and waking up from sleep. low arousal threshold. When we get stressed, our breathing pattern changes. Our breathing becomes faster, we sigh more, we tend to breathe more through an open mouth, we have noticeable breathing, and we use the upper chest. And on the basis of that, the key aspect for bringing the body from a stress state into relaxation is to do the opposite. Stress breathing is fast, therefore to relax the body we should really slow down breathing. Stress breathing is irregular, therefore we need to emphasize regular breathing. Stress breathing is often through the mouth, therefore we need to breathe through the nose. Stressed breathing is noticeable breathing, therefore we need to enhance soft breathing. Stressed breathing is using the upper chest, therefore we need to learn diaphragmatic breathing. It's not a coincidence that the exact characteristics of our breathing during stress are the same characteristics that we typically see in a breathing pattern disorder. Stress changes breathing patterns, but breathing patterns, if we have dysfunctional breathing, feeds back into stress. Fast, upper chest, mouth breathing causes stress. Stress causes fast, upper chest, mouth breathing, and there is a feedback loop there. It's almost that it's a vicious circle. So how should we breathe? Breathing should be light, quiet, effortless, soft, through the nose, diaphragmatic, rhythmic, and gently paused in the exhale. And this is how we would have breathed until the factors of modern living changed our breathing. So it's been known for many years that respiratory acidosis and alkalosis have profound effects on the functioning of the brain. Forrester, for example, reported in 1924 that hyperventilation can provoke seizures in epileptic patients and that the elevation of inspired CO2 concentration can suppress them. Now we know some of the functions of carbon dioxide. One, it's a catalyst for the release of oxygen from the red blood cells. So hemoglobin, which carries the vast majority of oxygen in our blood, 98% of it, carbon dioxide is a necessary gas because as there's an increase of carbon dioxide, blood pH drops and hemoglobin releases oxygen from the red blood cells to the cells. A second factor is the effect on our blood vessels. If we breathe hard, we're losing carbon dioxide, and by losing carbon dioxide, blood vessels constrict. McGarry in 1984, in a paper called Hyperventilation, a diagnosis begging for recognition, said that every 1 millimeter drop of CO2 reduces blood flow to the brain by 2%. We also know from other papers that 30 seconds of hard breathing can lower arterial CO2 from normal of 40 millimeter of mercury pressure down to 20. Well, if there's a 20 millimeter drop of arterial CO2, it translates into a 40% reduction of blood flow to the brain, and that's as a result of 30 seconds of hard breathing. The variations in the partial pressure of alveolar CO2, which is CO2 in the lungs, which in turn will equate generally with arterial CO2, could influence cerebral functioning in several ways. Molecular carbon dioxide itself, since it is soluble in the nerve membrane, could act as a narcotic gas. Carbon dioxide or tissue pH can influence neuronal functioning by altering cerebral blood flow. So we spoke about that. It's just one of the functions of carbon dioxide, thus altering the partial pressure of oxygen in the tissue. The more powerful effects of elevated CO2 may probably be explained by a direct effect on the neuronal membrane. The brain, by regulating breathing, controls its own excitability. Another aspect that's really worthwhile taking into consideration is that a biochemical feature of strong emotion is a rise in adrenaline and noradrenaline, and this has been shown to boost the body's sensitivity to carbon dioxide by about 30%, which in turn results in increased hyperventilation. The primary stimulus to breathe is carbon dioxide. The central chemoreceptors in the brain are monitoring mainly CO2 during regular breathing. But if you've got an increased sensitivity to carbon dioxide, it means that your breathing is going to be hard. And with hard and fast breathing, it's going to feed back into anxiety. So strong emotion, by changing and by increasing adrenaline and noradrenaline, is increasing the body's sensitivity to CO2. And with increased sensitivity to CO2, breathing is faster and it's feeding back into agitation. Is there a link between hyperventilation and exhaustion? Chronic stress is among the most common diagnoses in Sweden, most commonly in the form of exhaustion syndrome. We often see this in the corporate world. Individuals, they're under a lot of pressures. Employees are pitted against each other. Targets are set. There's a lot of competitive pressure, and employees, they're under a lot of stress in order to achieve these targets, and what's more, that these targets are changing. Severe stress symptoms occur if there's an imbalance between the investing and regaining of energy, and if it persists over a long period of time. In other words, as human beings, if we have a period of stress, we also need to have a period of relaxation for recuperation. But a good quality sleep is also conducive to this. If you were under stress during the day, it's very important that the body can recover by having deep quality sleep. But if you...
So, you know, what have I said ad nauseum, like over and over and over and over? If you can help the body relax a little bit and you can support restorative sleep, and that's all we do, that's enough. That makes, you know, and that's what a good moderate pressure general massage with nice focus on the torso does. Linda, have you got a question?
I just see most of my life being that way.
I know. That's why I'm particularly glad that you're hearing this, because I remember, yes. I mean, you're better than you were. But when you first started class, my goodness, all we had to do was mention work and you were all over the place.
I know.
And you immediately got angry. And, you know, now I don't know that work has changed that much, but I do know that you have changed.
I feel I have changed.
And so, you know, I used to be that way. You know, in my early 20s, I was pretty hot-headed. And yes. I had that anxiety that was underneath me all the time.
Yes.
So it would manifest into a panic attack. If I couldn't kind of release that with an anger episode, then it would show up as panic.
My anxiety, how I compensated was everything was anger.
Mm-hmm.
Everything.
Now you should be very proud of yourself.
Oh, I am. Absolutely, I am.
Because you're so different than when you first started class.
Yes. Oh, I feel I am too.
So this is only going to create more ahas with you as we go on.
But I just noticed the breathing in me, just since having to wear the mask all day at work, there's a heaviness in my chest and everything.
Yeah, that some awareness can eventually come with this.
Yeah.
Especially if you go back into and search for him, and you specifically look at the video that he's got related to breathing in a mask. Because I don't have that one up to watch.
Okay, I'm writing his name down so I can go back and watch his stuff.
Such a nice accent. Well, to us it's an accent. It's not one. But isn't he just soothing to listen to?
Yes.
Yeah.
Individual that due to prolonged stress, they can't switch off when they go to sleep.
Do you have something, Joanne?
No.
No, okay.
They have insomnia. They're twisting and turning all night. They're not having a deep sleep, so there's no time for the body to recover. Chronic stress symptoms usually occur within 3 areas: emotional exhaustion, physical tiredness, and cognitive difficulties. The majority of these patients with chronic exhaustion syndrome also have disturbed breathing, hyperventilation. 30 patients with exhaustion syndrome and 14 healthy subjects were evaluated with the Nijmegen Symptom Questionnaire. Patients with exhaustion syndrome reported significantly higher levels of hyperventilation as compared to healthy subjects. all patients' average score on the Nijmegen questionnaire was 26.57 with exhaustion syndrome, while that of the healthy subjects was 15.14.
Now that's what I showed you where I posted that, so you can get a copy and download that on Canvas, okay?
The Nijmegen questionnaire is a series of questions, and if you score over 23 out of 64, it is suggestive that you have hyperventilation syndrome. Now, it's not surprising that individuals with exhaustion syndrome have hyperventilation syndrome. The stress response, which increases their breathing. The increased breathing takes its toll because there's a change in biochemistry of the blood, biomechanics of breathing, and feeding back into stress. And at some point, the body becomes exhausted. Even when the stress is removed, even if the individual gives up work and goes into rest and recovery, hyperventilation will continue. In other words, the behavior continues even when the stimulus is removed. And that's due to neuroplasticity. And this is why breathing rehabilitation, breathing re-education is also very important for people who are recovering from stress, from trauma, anxiety. So in this paper, they taught brief grounding training, and it contributed to a near significant reduction in hyperventilation and significant reductions in exhaustion scores and scores of depression and anxiety. The conclusion is that hyperventilation is common in exhaustion syndrome patients, and it can be reduced by systematic physical therapy such as grounding. In addressing hyperventilation, there is a need to slow down breathing volume, to reduce the respiratory rate, but also to make sure that the tidal volume isn't increasing as a compensatory mechanism. In other words, addressing hyperventilation is about reducing minute ventilation towards normal. We do that specifically, and what's more, we use the control pause measurement as a feedback of the sensitivity of the body to carbon dioxide. We want to reduce the sensitivity of the body to CO2, to reduce the ventilatory response to CO2, and we know that's happening when the control pause is increasing. A few weeks ago, I had a client presenting with bipolar depression. This lady has been suffering from bipolar for 20 years. And during the course of our conversation, I asked, how does she feel when she wakes up in the morning? She said she feels exhausted. I said, has your doctor ever said to you that you may need to do a sleep study? And she said no. Now the question here to ask is it that the bipolar is causing the sleep problems, or is it the inadequate sleep quality which is feeding into depression? Insomnia is a known risk factor for the incidence and severity of depression, the recurrence of depressive episodes, and even suicide. If sleep quality isn't right, how can the mind be right? There are several studies have shown that obstructive sleep apnea can also contribute to the development of depression. Now, in terms of breathing, when we are doing breathing re-education, we are looking at improving insomnia, to reduce insomnia, to achieve deeper sleep, that the individuals wake up feeling more refreshed. We are also using breathing re-education to help reduce neuronal excitability, to increase blood flow to the brain, but also to change the relationship between poor breathing patterns and stress and anxiety and depression. When insomnia and obstructive sleep apnea co-occurred, depression scores were higher than those with insomnia alone. So the individual, again, if they have insomnia and obstructive sleep apnea and are waking up exhausted, how do you know why are they waking up exhausted? Are they waking up exhausted due to the insomnia, or are they waking up exhausted due to the depression? And of course, if you're continuously exhausted and fatigued, you can't function in normal everyday life, and that in turn is going to increase anxiety and, of course, depression. As estimates of the prevalence of insomnia among OSA patients are as high as 67%, this finding suggests that many obstructive sleep apnea patients may be at risk of depression by virtue of the comorbid insomnia symptoms. The presence of daytime sequelae such as fatigue, irritability and cognitive symptoms are part of the diagnostic criteria for insomnia disorder. These daytime symptoms are often what prompt patients to seek treatment. However, daytime sleepiness, irritability, fatigue, and cognitive dysfunction are also well characterized consequences of sleep apnea. So there's a commonality in terms of the symptoms, and can we help them? Yes, we can, by changing breathing patterns. This paper here is examining the relationship between respiratory regulation and childhood anxiety disorders of 104 children aged between 9 and 17 years of age. Childhood anxiety disorders, particularly separation anxiety disorders, are associated with CO2 hypersensitivity. Carbon dioxide hypersensitivity is associated with physiological changes similar to those found in panic disorders. Now, what does it mean, carbon dioxide hypersensitivity? It means that if there's an accumulation of carbon dioxide in the blood, and as carbon dioxide is the primary stimulus to breathe, you have an exaggerated response to the accumulation of CO2, your breathing is going to be harder. But also, if there's an accumulation of CO2 in the blood, when you've got a high sensitivity to it, you're more likely to feel suffocated. Now, the individual then who is feeling suffocated, that in turn will feed into symptoms of panic. They hyperventilate to get rid of too much CO2. Now there's reduced blood flow to the brain, there's reduced oxygen delivery to the brain. This in turn increases neuronal excitation. So a traditional remedy for somebody having a panic attack was to breathe in and out of a bag. The purpose of breathing in and out of a bag was not to bring in oxygen, but of course to trap carbon dioxide from the exhaled breath, to bring carbon dioxide into the lungs, to increase it in the blood, to increase blood flow to the brain, to increase oxygen delivery to the brain, to calm down the individual. However, it's not the stress that's the problem. The problem is everyday breathing patterns. When one is hypersensitive to carbon dioxide, it doesn't take much to push one into symptoms. These individuals are teetering on the brink of symptoms, and all it takes is a little bit of a stress, such as driving a car, being in a crowded place, etc., just to push one into symptoms. Carbon dioxide sensitivity is postulated to be a family risk marker of panic disorder. During CO2 inhalation, offspring with anxiety disorders relative to offspring without anxiety disorders experience significantly more panic symptoms and panic attacks, as well as elevated respiratory rates. So in the test, they would have individuals breathe in carbon dioxide just to see how is their body reacting to it. Now bear in mind, our body is producing carbon dioxide as a normal process of our metabolism. And the amount of carbon dioxide that we need in our blood, in our lungs, is about 5%. We can change the sensitivity of the body to carbon dioxide by deliberately slowing down the breath, and also by using very tailored breath hold exercises. So with a client coming into me, I will gauge if they have a hypersensitivity to carbon dioxide by virtue of their control pause. I can also gauge it when I have them do the exercises and I see how do they respond to the increase of CO2. Individuals with a strong sensitivity to CO2, we give them small breath hold exercises or small paces or gentle reduced breathing for very short periods of time. So for example, we want to restore nasal breathing and light breathing with relaxation, but there is a specific protocol for individuals who are coming in with panic disorders, especially when they have a hypersensitivity to carbon dioxide. This is a really interesting study. It's looking at 41 patients with panic disorder and agoraphobia. They did 4 weeks of training aimed at altering either their respiration or they did cognitive training. The changes in respiration, symptom appraisal, modality non-specific mediator were considered as possible mediators. So by slowing down the breath, they used capnometry assisted respiration training. So basically there's a feedback that the individual is following from a computer screen, and it's designed that you're following the movement on the screen and that you're slowing down your breathing in coherence with the movement on the screen. But what was interesting about it is that breathing retraining, but not cognitive training, led to corrections from initially hypocapnic to normocapnic ranges. In other words, the necessity with breathing re-education to normalize carbon dioxide.
Now, that's important because, you know, we talk about cognitive behavioral therapy and that sort of thing, but that is challenging people to identify a lot of psychosocial behaviors that they have that may be even quite painful for them. But when they mechanize it and put it into an activity or an exercise or something that's very concrete, and you can still get changes in how a person is perceiving their world, then they're more apt to do that because it's less emotionally painful. Does that make sense?
It does.
Linda, can you appreciate that?
Yes, everything that he is saying is like really hitting me in the face, you know, just
So, you know, that's I've said this over and over with massage, is that the clients that have, and we all have had things that are painful, emotionally and spiritually painful. We've all had those things. And we found a way to cope. It may not be the most successful way, but we have found ways to cope. And if we look back on behaviors, especially when you look at something like the breathing, because screaming and hollering and throwing things around is a very good way to regulate this oxygen carbon dioxide balance that he's talking about, because it's exhale plus activity. It's just not very pleasant for everybody, but it works. It works.
yes.
So without having kind of a conscious awareness on this, and then this being very mechanistic, it helps persons start to regulate physiologically, kind of from a brainstem area. And then once that is a little better, then maybe they can find intellectually and emotionally some understanding about why they have acted the way they have in the past, or why they are acting the way they are now. And they can be a little gentler with themselves and go, okay, I understand how that was a solution. I get it. It's just that nobody else wants to be around me when I am having this solution.
Right.
The question I have, people with a little bit of claustrophobic, it happens quickly and the breathing is difficult. I've had it just a couple times in my life where I just took short breaths and drank water.
Yeah.
Just to get past it. And I'm not bad, but you think of some people who get very claustrophobic quickly.
It limits their world.
Yeah.
I'm very claustrophobic, and with all of this stuff going on, our shop has, okay, I understand we have to do the safety glasses with the side shields. And then we went to earplugs to help our hearing. And now we're doing the masks. At first I couldn't do the earplugs and the masks at the same time. I was closing myself in too much and I just couldn't do it. And then they started griping at me, well, you have to do this. And I'm thinking, I told them, I says, I just can't right now. And slowly worked myself into it where now I can wear the earplugs, but it still feels like I get hot.
Yeah.
I get hot. And
well, carbon dioxide is a vasodilator.
Right.
Which is going to make you hot and feel flushed.
Yes.
Yeah. So, okay, good.
Patients learn to breathe in such a way as to reverse hyperventilation, a highly uncomfortable state whereby the bloodstream operates with abnormally low levels of carbon dioxide. Most panic disorder patients report that they are terrified of the physical symptoms, such as shortness of breath or dizziness. But these symptoms are also typical symptoms that we see in individuals with hyperventilation-related symptoms. But these symptoms are also symptoms that we see very much in patients with hyperventilation syndrome. In this study here, cognitive therapy didn't change respiratory physiology, that it was necessary to practice slow breathing to effectively reduce hyperventilation. So slow breathing was proved an effective and powerful treatment that reduces the panic by means of normalizing respiratory physiology. If you think of it, normally somebody with anxiety, somebody with panic disorders, they go to cognitive behavioral therapy, which is absolutely excellent. They do counseling. But it doesn't necessarily mean that the biochemistry and the physiology of their breathing is changing. We also need to address breathing pattern disorders, because otherwise, if they have a hypersensitivity to CO2, it's going to keep on feeding back into their symptoms. We also need to look at these individuals' sleep. We can't just rely on cognitive behavioral therapy. It produces results, but it's not the whole picture. Look at breathing, look at sleep, look at cognitive behavioral therapy. In this study, they found that slow breathing, it's the therapeutic change in carbon dioxide that changes the panic symptoms, not the vice versa. During the treatment, patients undergo simple breathing exercises twice a day. A portable capnometer device supplies feedback during the exercises on the patient's CO2 levels. The goal of these exercises is to reduce chronic and acute hyperventilation and associated physical symptoms, and it's the exact goal of when we're working with breathing re-education. The Buteyko breathing method was specifically designed to help reverse chronic hyperventilation. This is achieved by breathing slowly, but most importantly by breathing lightly. Contrary to lay belief, taking a deep breath actually worsens hyperventilation and symptoms. Now, historically, and also, we commonly hear it that when an individual is stressed, when they're feeling anxious, when they're feeling depressed, take a deep breath. They respond by taking this big breath, and of course the big breath isn't going to increase blood flow and oxygen delivery to the brain. The big breath will feel a little bit better because you're stretching everything and you're relaxing it, but it's not changing the biochemistry. In actual fact, a big breath taken every few minutes is enough to keep that person stuck in hyperventilation and stuck in symptoms.
So this is where I get a little perturbed in the bodywork community, massage, but I am also including yoga and some of the other methods that are out there. They try to control somebody's breathing. They'll say, okay, just take a deep breath now, just breathe through it. And what did we just learn?
That can make it worse.
Yeah. So, both of you have been in class with me forever. So, I will say, now don't you observe their breathing. Don't direct their breathing. Notice when they're able to slow it down or whatever, but boy, it's pervasive. Somebody will do a trigger point thing or whatever, and then they'll say, now breathe through it. Now just breathe through it. And that doesn't help. Sometimes the breath holding, which is going to start the shift of this carbon dioxide, is actually what is causing the improvement. And then we interfere with that when we tell them breathe. So the breath holding or the pause between makes a big difference. And you already alluded to that when you were talking about how you had been taught to breathe in, breathe out, gentle hold, that sort of thing. Yeah.
Cognitive behavioral therapy, if a patient reports shortness of breath, the therapist challenges the assumption by asking how often the person actually has suffocated during a panic attack, then hopes that this will reverse the patient's thinking. But shortness of breath is a typical symptom from breathing pattern disorders. The researcher continues that he finds the process is very challenging for some of his patients because it acknowledges the symptom but says it's not a problem. Slow breathing, however, tells us that a patient's CO2 is very low and is causing many of their symptoms. And it can also show how to change these symptoms through correct breathing. There has been an assumption that if people worry less about their symptoms, it will normalize their physiology, but this study shows that this is not the case. So even if the patient worries less about their symptoms, hyperventilation remains unchanged, and this is a risk factor for relapse down the road. Apart from hyperventilation being a symptom generator, it's an unhealthy biological state associated with negative health outcomes. Most investigators report an exaggerated response among individuals with panic disorder and at least some of the respiratory parameters. However, some studies have failed to observe this effect. There is an important link between respiration and arterial blood CO2 levels. Specifically, in terms of respiration, 3 parameters are responsible for controlling respiratory processes: arterial blood levels of oxygen, carbon dioxide and hydrogen ions. Amongst these, carbon dioxide provides the strongest stimulus to ventilation. For example, a slight increase of CO2, 2 to 5 millimeter of mercury pressure in the arterial blood can more than double ventilation. So in other words, carbon dioxide, that the body is very sensitive to an increase of CO2. But with some individuals, the body is overly sensitive to the increase of CO2. Findings show that individuals with panic disorders are prone to experience panic attacks when inhaling CO2 enriched air. This has given rise to the hypothesis that physiological systems underlying the experience of suffocation may be important in the etiology of panic disorders. What's causing the suffocation is the individual's sensitivity to carbon dioxide. And these individuals have abnormal breathing patterns. So I, as a breathing therapist, I look at the person coming into me with panic disorders. I see that they breathe fast, they sigh, they breathe often through an open mouth, they breathe using their upper chest, and I know by measuring their control pulse whether they have a hypersensitivity to buildup of CO2. Those individuals with a low control pulse, their breathing is very fast and they have an exaggerated response to the accumulation of carbon dioxide, and this can often be interpreted as suffocation, which of course is going to feed back into the condition. In this paper, 40 individuals with panic disorders and 32 controls underwent both a breath-holding challenge and a CO2 rebreathing challenge. Individuals with panic disorders experienced elevated physiological reactivity to both challenges and a greater levels of suffocation sensations during the rebreathing challenge. And furthermore, panic disorder individuals who experienced a panic attack in response to the rebreathing challenge exhibited faster but shallower breathing during the challenge than did other panic disorder individuals. These findings are consistent with the theories linking panic disorders to hypersensitive brain systems underlying the experience of suffocation. The continuous rebreathing of 5% CO2 as well as inhalation of 35% CO2 has been found to initiate panic attacks significantly more often in individuals with panic disorders than in individuals with other anxiety disorders or unhealthy control. Furthermore, individuals with panic disorders experience CO2-induced panic attacks as being very similar to naturally occurring attacks. So again, it's the sensitivity, it's the feeling of suffocation brought about by the individual's sensitivity to the carbon dioxide and the same suffocation that they would experience during an attack. Consistent with most earlier studies, but not all, we found that individuals with panic disorders scored significantly higher than did healthy controls on subjective CO2 challenge responses. For example, panic attack rate and subjective suffocation, as well as respiratory-related CO2 challenge responses, breath-holding and ventilatory response. Briefly summarised, these models posit that a panic attack results from a catastrophic misinterpretation of bodily sensations which are seen as indicative of a serious physiological danger or loss of control. In my earlier years when I was working, and I still work with people with anxiety and panic disorders, however, experience is a great teacher. But in my earlier years, I would see people coming in with panic disorders. I would have them slow down their breathing to create air hunger, and I could witness that they were having panic sensations in front of me, that they had an immense fear as a result of air hunger. And as a result, over the years, I've had to tailor the exercises to suit these individuals to take into consideration the hypersensitivity that these people had to carbon dioxide. For hyperventilation, there is an accumulating evidence that at least some panic attacks are accompanied by drops in alveolar carbon dioxide. Between 61 and 83% of patients with agoraphobia with panic recognize the similarity of their symptoms of voluntary hyperventilation and their usual panic attacks. In other words, they have the individual breathe hard for 1 to 3 minutes, and that the symptoms produced during the hard breathing, during the hyperventilation provocation test, were similar to their normal panic attacks. Here we have to wonder about the connection between breathing hard and the initiation of the panic disorder and symptoms. Hyperventilation, it may take place chronically or in response to a provoking stimulus, such as being in a stressful environment or exercise. Really what it boils down to is the person's resilience. As human beings, we need to be able to cope with a certain amount of stress. We need to be able to cope with a certain amount of physical exercise. But if breathing patterns are dysfunctional, if we have developed chronic hyperventilation syndrome, our resilience is very much depleted. It doesn't take much to push us into symptoms. Normalizing breathing volume. The effect of breathing therapy was evaluated in patients with hyperventilation syndrome. Efforts to reduce ventilation through exclusive attention to the reduction in respiratory frequency may not be successful in reducing ventilation, but also can paradoxically increase ventilation. This point here is that if you are a counsellor or if you're a therapist and you're working with somebody presenting with hyperventilation syndrome, if you say to them, okay, your breathing is too fast, you are breathing 20 breaths per minute. Instead of breathing 20 breaths per minute, I need you to breathe 10 breaths per minute. Here you're looking to reduce the respiratory rate. But in that process, as this paper is pointing out, as the respiratory rate was reduced, the tidal volume increased. And not only that, it overly compensated that the actual minute ventilation was increasing. So that the reduction to the respiratory rate alone actually contributed to hyperventilation because minute ventilation increased as a result of it. If we are reducing respiratory rate, we also need to make sure that tidal volume doesn't increase overly to compensate. That we need to be looking at both the respiratory rate and the tidal volume to ensure that minute ventilation is reduced.
So what this means is that people took fewer breaths, but they breathed in more air with each breath. Does that make sense?
I was just trying to think of that too.
Yeah.
They were almost, I guess, hyperventilating, taking in so much and then trying to hold it to cut down on the amount of times they breathe within a minute.
That's exactly right. Okay, I just wanted to make sure you understood that.
Since ventilation is measured in terms of minute volume, the sum of the tidal volumes in each breath for 1 minute, a decline in the partial pressure of carbon dioxide accompanied by a decrease in respiratory rate can only be accomplished by a means of an increase in minute ventilation. So the point here is that yes, reducing respiratory rate alone, it can lead to an increase of minute ventilation, which corresponds to a decrease of the partial pressure of carbon dioxide. The influence of breathing retraining on complaints has been studied extensively in patients with hyperventilation syndrome and with anxiety disorders. The findings display a decrease of frequency and intensity of panic attacks and improvement of coping ability in stressful situations after breathing therapy. This was confirmed by the present study, that is, that the complaints and anxiety decreased significantly following breathing therapy. 10 of the 16 complaints of the Nijmegen questionnaire improved significantly. The state anxiety was reduced, however, trait anxiety did not decrease, except in the patients who reported the largest subjective improvement. Breathing retraining, it markedly modified the breathing pattern, patients learning to breathe slower, and older patients learning to breathe deeper. Several investigators mentioned a slowing down of breathing frequency and an increase of the fraction of expired carbon dioxide. Others, however, did not. The complaints which turned out to be linked to breathing were chest pain, a tense feeling, blurred vision, faster or deeper breathing, palpitations, and an anxious feeling. In the studies, carbon dioxide doesn't always show to improve It therefore could be concluded that breathing retraining doesn't work because it corrects hyperventilation. In other words, the patients are feeling better, but what's actually happening here? Slowing down the breath, is it addressing hyperventilation or is it not? Because if carbon dioxide isn't showing to improve, it's not necessarily then due to hyperventilation, but it could be the mechanism of their breathing. We know that hard, fast, shallow breathing through the mouth will initiate and increase panic and anxiety. So therefore, the fundamental aspect of what we're looking to do is we're looking to make breathing through the nose using the diaphragm in a slow manner, in a quiet manner and regular. We know that breathing is happening more that way when the control pose is increasing. Our objective is that the individual develops light breathing both during wakefulness and during sleep as key modifications in the quest for improving and reducing the symptoms of anxiety, stress, panic disorders and depression.
So he's got this particular system, but there are many symptoms that do this. You mentioned it. An inhale, a control pause is when you're not breathing, and then a slower exhale through the nose. So for us, we're not necessarily respiratory therapists, but if a person has been breathing as an upper chest breather for a long time, they've developed a musculoskeletal habit. And there's been a change in the tone and stuff. And accessory breathing muscles, which is pretty much anything that attaches to the ribs, that are supposed to be used for other stuff, if they increase in tone or the density, the connective tissue thickens in that area, it's going to then have its own result. For example, up here in the scalenes, that brachial plexus has got to get through there. And if we're upper chest breathing, and we're using the scalenes to breathe with, instead of stabilizers of the head, or the cervical vertebrae, not the head, but the cervical vertebrae, then the space that those nerves have to get through diminishes. Now we get brachial plexus and thoracic outlet syndrome. And then there's also evidence that instability in the low back, hypermobility, can be controlled if the lumbar dorsal fascia is stiffer. But the way to stiffen that up is to overbreathe. So if you create more stability around your low back by overbreathing, I mean, it's just a nightmare. It becomes this circle, 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 circle. So the last video I want to show you is him working with a child. And it shows how to clear the nose and how to work with some breathing. And it goes along with and enhances the stuff that's in the book. So, okay, so I have to do this. And I think it is this one. So I have to open that one up. We'll see, just a second. Yep, this is the one. So now I have to come back to you guys, and then I have to share the screen, and I have to talk myself through this.
That's fine.
Okay, can you see it?
Yes.
All right.
Exercise, we usually call it exercise 1. This is the nose and blocking exercise. So if you do this for me, block one nostril, breathe hard. Oh, there's a little bit of obstruction there. Now try the other one. Oh, and the left one is totally free, isn't it? Yeah. So your left.
So we should do this with them. All right. So I'm going to start this over, and let's just Let's just pretend we're this little girl, okay?
Now we're going to go on to the next exercise. We usually call it exercise 1. This is the nose and blocking exercise. So if you do this for me, block one nostril, breathe hard. Oh, there's a little bit of obstruction there. Now try the other one. Oh, and the left one is totally free, isn't it? So your left one is totally open and your right one is a little bit stuffy. So we're going to see, can we open it up? Because if the nose is stuffy, it's probably more likely that we're going to mouth breathe, because mouth breathing can be caused by air hunger. And air hunger can be due to a number of factors. One is that the nose is just a little bit too small. So genetically, we just might have a smaller nose. And as a result, we feel air hunger breathing through it. However, continue breathing through it. So you could have a perfect nose, but if it's just a little bit smaller, the air hunger may cause you to switch to mouth breathing. But I'd say, don't switch to mouth breathing. Keep breathing through your nose because the air hunger goes away. And obstruction, but we can help open up the nose. So we know that your right nostril is a little bit stuffy. To open up the nose, take a normal breath into your nose, same as before. Normal breath out, pinch your nose and hold. Gently nod your head, just ever so gently. Good girl. Keep going, keep holding, and hold for as long as you can, and then let go. So even try letting go there. Let go there and breathe in. Excellent, excellent. So I was just saying, how long were you holding your breath for? And now just have normal breathing. Breathe as normal. So we do this exercise 6 times. And if we have a head cold, it will generally open it up. Since 1923, it has been known that when man or woman or kid, child, holds their breath, they can open up their nose. It's pretty amazing, isn't it? Since 1923. Okay, so it's like magic. It literally, when you hold your breath, it opens up the nose. So if you've got a head cold or if you've got rhinitis, and we know that in the United States, 40% of children have rhinitis. And it's probably pretty similar in Europe and in Ireland. Okay? And again, take a normal breath into your nose, normal breath out, pinch your nose, and gently nod your head up and down. So you're swimming underwater. Keep going. You know, all that stuff that you're throwing into the bottom of the pool. Keep going. Keep swimming. Keep holding your breath. Keep going for as long as you can. Excellent. That's it. Excellent. And it's a very normal thing for human beings to hold their breath. When you go swimming, do you sometimes throw something down to the bottom of the pool? Yeah. What's it called?
Diving sticks.
Oh, it's a diving stick, is it? So you throw it down and then you dive in afterwards. Yeah. And you're swimming underwater like a fish and you're coming back up. So that's what this exercise is like. So I want you to pretend that you're underwater. So you're going down for the diving stick, yeah?
Okay.
So again, whenever you're ready, normal breath into your nose and out through your nose. Pinch your nose, good girl. And gently nod your head up and down. Keep going, keep going, keep going. So you're swimming underwater and you're swimming for as long as you can. And keep going, you're swimming for as long. That's it. And you're really holding the breath for as long as you can. That's good, you're doing it correctly. That's good. All of this will improve. It just takes practice, yeah? It takes plenty of practice. So you're just breathing normal now for about 30 seconds or so. So 30 seconds to a minute just to kind of get your breathing back to normal. Oh, if that's all right. And then we'll do it again. So we're going to do it a few times. So if there was a little bit of mucus trapped in the lungs, sometimes we can bring that up as well. So again, normal breath in through your nose and out through your nose. Pinch your nose and hold. And you're going down after your diving stick. So you can pretend that you're underwater. You're gently moving your head up and down, ever so gently up and down. Keep going, keep going, keep going. Good girl. So the whole emphasis is when you let go, you want to breathe in through your nose. So we'll do that a few times and then we'll do some breathing exercises, yeah? Okay. So you're still feeling, do you have to think about your lips together now or is it happening naturally?
It's happening naturally.
It is. So you feel the tape is drawing the lips together. And that's really good. So you can still communicate. You could be watching TV or you could be reading your book, playing with toys. So it's really important when children are distracted. That's when we get them wearing myo tape. So because if they forget about the mouth open, the tape is going to automatically remind them to bring their lips together because they feel the tension. Yeah? And again, normal breath in through your nose, normal breath out, pinch your nose and hold. Good girl. Gently nod your head up and down, holding your breath. Keep going, keep holding, keep going, keep going, keep going. You're underwater, you're going down for your diving stick, keep going. Excellent. Always, and breathe in at the end. So when you let go, try and breathe in as opposed to breathe out. Without getting too technical, well, I suppose I am in a way, but as you hold your breath, nitric oxide, there's a gas called nitric oxide that builds up in the nasal cavity. And when you release your nose, you want to breathe in, so you're carrying that nitric oxide into your lungs, and it opens up the airway like magic. So just as it opens up our nose, it also opens up our lungs, because it's one airway. It's not that the nose is totally disconnected to the lungs. The nose and the throat and the trachea and the bronchi and the bronchioles, all connected. So that's why it's very important that we breathe through our nose to protect the lungs. And again, Laurie, take a normal breath in through your nose, normal breath out, pinch your nose, hold, gently nod your head up and down, keep holding, good girl, keep going, keep going, keep holding, keep going, keep going, keep going, good girl. Okay, and when you're in school, do you sometimes hear the kids coughing around you?
Yeah.
Yeah, I'd say it's fairly common, is it, especially this time of year?
Yeah.
Okay, so do you think it makes sense that if there was a child beside me and the child is coughing, cough, 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 and during the coughing, what comes out of the mouth? Germs? Yeah. And another child is sitting there with the mouth open, and you've got one child that's coughing and all the germs is coming out of that child's mouth. Do you know what I would be doing?
Breathing through my nose.
Absolutely, because what will that do?
That will stop you from getting germs.
Exactly. And even if the germs comes into the nose is able to deal with it, but the mouth isn't. It doesn't make sense, does it? That if there's a child coughing and you have another child with their mouth open, so all the germs is coming out of one child's mouth and into another child's mouth. That kind of doesn't make sense. A bit gross, really, isn't it? Yeah, I think if once the kids realise that, it will really encourage them to breathe through the nose. Yeah? Okay. Shall we go again? Normal breath in through your nose, normal breath out, pinch your nose, hold, excellent, keep going, keep going, keep going. So you're going down for your diving stick, excellent, keep going, keep holding for as long as you can, keep going, excellent stuff, well done. And that will start to free up the nose. And when we can open up the front part of the nose, we know then that the obstruction is due to rhinitis. So the child may have hay fever, which would be allergic rhinitis, or they might just have a stuffy nose all the time, which is perennial rhinitis. Now, if the child, if after doing this exercise, if they keep on wanting to open the mouth because of air hunger, if they're doing the exercise correctly, we have to suspect that the problem is the back of the nose, and that may be that the adenoids are enlarged. But enlarged adenoids by themselves would rarely cause mouth breathing, except when the airway is small. And this is where dentists have such an important role to play. A really aware dentist, when they're looking into the child's mouth, they should be checking, does the child have a high narrow palate? Does the child have a narrow maxilla? You know, are the jaws just a little bit set back or a little bit narrow? In other words, anatomically, does the child have a good airway? Because a good airway is absolutely vital for sports and for sleep. And what's more, not just a good airway, because breathing is pretty important, isn't it? Yeah. You know, we can't survive it for, you know, if we stopped breathing, like you can hold your breath for a few seconds, maybe for a minute, but that's about it, you know. So breathing is so important. So with breathing, airway is very important. And airway is the pipe that takes the air from the nose to the lungs. And oxygen is transferring from the lungs into the blood. And that oxygen-enriched blood then is delivering oxygen to the cells. And that's fueling the metabolism. So when you go for a run, you need oxygen. And that's influenced by breathing through your nose. You get more oxygen into your blood by breathing through your nose rather than less. And nose breathing is also targeting our main breathing muscle, the diaphragm. Can we go again? Yeah. Normal breath in through your nose and out. Pinch your nose, hold, and nod your head up and down. Keep going, keep holding, keep going, keep going, keep going, keep going, keep going, keep going, keep going. Excellent. Okay, so you might have a little bit of a head cold at the moment. Just block that, you do. Just block the left nostril. That one was free anyway, wasn't it? And now try the other one. Okay. It sounds better. Does it feel any different?
Yeah.
Yeah, it feels better. So you've literally opened up your right nostril quite a bit there by just simply holding the breath. So we want the boys and girls at home to practice the same thing, don't we?
Yeah.
So we'll show them once more so that they remember. And remember all of those reasons for breathing in through the nose. If a child is coughing in school, lips are together. For sports, for looking intelligent, for sleep, for focus, for concentration, being able to do the homework, having our attention to do what we can do in school. Very important. And also nose breathing, it makes sure that our mouth is moist. When we have a moist mouth, we have less dental problems. Yeah. So we want the tongue resting up in the roof of the mouth. And the lips should be closed. So we're breathing in and out through our
mouth.
Okay, so let's do it again. So you ready? Normal breath in through your nose and out through your nose. Pinch your nose. Excellent. And gently nod your head up and down. Keep going. So you're swimming underwater, going down for your diving stick, and it's down a long way. Keep going, keep going, keep going, keep going. You have to stick. Now you're coming back up. Excellent. And in through your nose. That's how you open up your nose. That's how you open up your nose. Okay, so that was an excellent doing that exercise. Well done. You've really done well. You've held your lips are together throughout, and the tape is helping with that. You're breathing in and out through your nose. And what's more, you know what your nose is for. Looking intelligent. If the child is coughing in school, your sports, your sleep, your homework, your focus, to help protect your teeth. And also having the tongue in the roof of the mouth, which is helping to open up the airway. So it's really, really vitally important, yeah? And we know that you can breathe functionally through the nose because you've had your mouth closed with the tape on for quite a few minutes. Okay, so we go on to the next exercise.
Yeah.
Excellent, okay.
So let me get out of this. So that was pretty, wasn't he gentle with her?
That was very good.
So we're running. So he's got more YouTube videos up. So we're catching on to noon here. And let me look at the PowerPoint real quick and let's see where we're at. So that was really good. That was what I had for us to do for today, awesome. Which is fitting in with your schedule, Linda, and also yes. For Joanne. How about if we do this? It'd be the same link as we had today. What if we let you absorb the information, have time to look through the material in the book, and then we get together at 9 o'clock tomorrow for maybe an hour or so.
Okay.
And let this stuff absorb, and maybe we can bring in some overlapping stuff on how this all wraps together. But I can tell that you've had an aha on this.
I definitely have. And I think this might have been a lot of my problem for my learning in school. So many dysfunctions.
Well, but look at, you're still alive and you're still upright and you're still learning.
Oh, absolutely.
So absolutely. Now, the only other little assignment I would give you is to go on YouTube, find this gentleman's videos and look at the one with the mask.
Okay.
You've talked about that, and then we can talk about that some more. So we'll reconvene Looking Intelligent at 9 o'clock tomorrow morning. We can use the exact same link, okay?
Oh, okay, that sounds good.
Go shovel, Joanne.
Oh, I need to have a little bit of salad first. I'm hungry.
Yeah, I'm hungry too.
Yes, salad sounds really good right now too.
All right, everybody.
All right, we'll see you tomorrow.
All right.
Bye.
Bye.